Good afternoon, everybody. We are live with 12 viewers at this time. We'll give it a minute. All right, we are live. Whenever you want to go, or if you want to wait for a few more viewers.
We'll give it a minute. We usually start a few minutes late, so we'll just
No way.
No way, says the one who's in charge of getting the stream live and struggles.
Don't say that.
Oh, come on.
I would say sometimes we're on time. How about that? That sounds better.
Yeah, rarely. Okay. So I guess I'll just go through the usual updates about where we are real quick. Does that sound like what we should start with?
Sounds great.
Okay. Just get it pulled up here. All right, so good afternoon, everybody. For those of you who are on the LG call this morning, some of this will be a little bit repetitive, but I'm going to just give you a quick overview of sort of where we think we are right now, and then we're going to go into another system issue that is unrelated really to COVID, but something that's pretty important and we need to talk about. We will probably also record this session and post it to Target Solutions in some form because we do think it's a message that everybody needs to hear. So with that being said, we currently today have, as of yesterday morning, I guess, we're at about 105 hospitalized folks in Pinellas County from COVID, with roughly 30 in the ICU and roughly half of those on ventilators. So although the general testing numbers and the general hospitalization numbers are certainly trending down, and we love to see that, we are not anywhere close to zero with 30 ICU and 75-ish in the hospital, not in the ICU. So those numbers are encouraging. We have good ICU availability right now. We have obviously good ventilator availability, although ventilators have become, as everybody knows, much less important in this game as we've gotten better at treating this thing. I said very early on in this that I expected there was a high likelihood that as a frontline medical worker, I might get this virus, but that I very much wanted to not get this virus in the first couple of waves because I wanted us to know some more about it. And I think it's a bit encouraging that we are knowing more about it. We're getting better at treating it. But that being said, I still don't want to get it yet. We have more and more coming out about the inflammatory state associated with this infection, more and more coming out about the long-term sequelae that people can have from this, whether that's a pericarditis-like picture or a pulmonary direct damage type picture or a vascular damage type picture. On a weekly basis, there are studies coming out that seem to point to the other things associated with this virus besides just a respiratory infection. So our overall numbers in the hospitalization, bear in mind, those are a lagging indicator. So we would expect the hospitalizations to lag a couple weeks behind cases. We do see those coming down. I'll shift over now to another dashboard that kind of shows a compilation of some data sources into one dashboard and try to show you kind of where we're at there. This is testing data, but has some ED visit data in it as well as some hospital bed availability data. So as you can see, we had a bit of a spike in the spring. We came down, and then after some changes there, we had this big spike over the summer. which we are now sort of riding down. You will notice, though, probably that over the last 2 weeks, that percent positivity has crept up again a little bit. Some of us are concerned whether this is an early indication of problems we may have after people are going back to school, back to college, or after Labor Day weekend. Remains to be seen how this is going to play out. But it's sort of reminiscent of where we were right here. So we'll see how that goes. You can see there's just this very slight uptick here over the last week or two. So we're monitoring that very closely, waiting to see what happens there. The government at the state level is beginning to loosen up some of the restrictions, including on bars, although we're not sure exactly how much of an impact that's going to have, since many bars had already had food service and so never really fully closed. I would encourage you to just continue to be vigilant. I know it's painful, but I am still wearing an N95 mask and eye protection on every single patient encounter as a baseline, regardless of whether I suspect COVID. And I think it's prudent for all of us to do that. It's certainly still the standard at the hospital, and it's certainly still our standard here at EMS. So please continue to be vigilant, continue to protect each other and yourselves. I know we're all anxious for this to be over and to get back to normal, but to be, really, really, unvarnished about it, we're not going to be back to normal till well into 2021, and that's optimistic. So I do think that we will begin to hear more and more about vaccines and therapeutics as we go through the next few months. And I think that frontline healthcare workers and first responders will likely be among the very first to be vaccinated. I suspect we'll actually be given a stockpile of vaccine and be asked to vaccinate ourselves, and likely be asked to help vaccinate other areas of the community the same way we were asked to help out our long-term care facilities with PPE and procedural stuff earlier on in this. So I anticipate that that's coming pretty soon. Actually, we'll see just exactly which vaccine it is and the details of that in a little bit. There's a little bit more work that needs to be done on their phase 3 trials to get us to a point where it's time to do that. But I do see that coming down the pipe pretty darn quick at us. So stand by for that. Bear in mind, though, that even once we start the vaccination process, we will not be fully back to normal. This could be a multi-step process to get us to a point as a country where we can really get back to the way we normally did things. And, for the final ray of sunshine, I guess I would just point out that it's 2020, and this is our third coronavirus outbreak since the year 2000. And so we should expect to continue potentially to be having ongoing ones like this, hopefully not this severe, but every few years. Certainly there's no reason why that wouldn't happen, given how connected the world is right now. So I'll pause there for a minute for questions. If anybody has anything that they want to specifically ask related to COVID, clinical treatment, PPE, response, where we are generally with it, please go ahead and toss that up there. While we're waiting for that, Jasmine, do you have any updates about PHTLS or scheduling or anything else training-wise that you want to share while we're waiting?
Sure. Maybe a bit repetitive, but if you haven't heard it before, PHTLS is ongoing. If you're from Sunstar, you need to be signing up on Target Solutions. Otherwise, your agencies will be telling you when you need to go. Before you do go to that class, you need to do August CME, and the final test in August CME is the pre-test for PHTLS. So when you're complete with August CME, you have to go back into your history on Target Solutions and print out that certificate and bring it with you to PHTLS. That's your ticket to play, so that you could join the class. And it is N95s throughout the class. So just come a few minutes early, be prepared with an N95, or we will provide them for you. And make sure you open your book and study a bit beforehand. EMTs, we have a EMT CME out on Target Solutions right now. And there'll be another one coming out in November that'll make up those hours for you since you're not doing PHTLS.
Cool. All right. I see no questions coming in the chat related to COVID, which means probably we're all just sick of dealing with it, which I totally get. David, any COVID related quick comments before you talk about your other topic?
I don't think so. You want to talk about the IgG testing?
Sure. So the final packets of paperwork and directions and logistics for performing IgG testing are on their way out to all of your agencies. And the testing should commence within the next few days, next week, I believe, at the latest. And we will offer voluntary IgG testing to every person in the system. And that'll be done coordinated through your agency, performed by the lab at the hospital. And we will get results back to your agencies via your designated infection control officers. So I appreciate everybody's patience with this. It took a while to get it to fruition, but I am confident in this particular test and how it's being performed that this will be a legitimate result. And hopefully help to give us a little better understanding of the full impact of COVID on our workforce. So I'm certainly happy to take any questions that folks have about that. There is, for those of you who are on the call who are also DICOs or designated infection control officers, we will be having a Q&A session this coming Friday morning at 9 a.m. You should have gotten a Zoom link from David. If you haven't already, look for it. I think it went out a little while ago. And we will do a Q&A session with myself and David to make sure that all the DICOs have their questions answered and can serve as a point of reference for their individual agency folks. All right, with that, I'm gonna go ahead and turn it over to David to talk about a topic that came up at EMS LG this morning and had some interesting discussion, and I wanted to share with the group and also capture in a recorded fashion his discussion of this so that everybody could provide their feedback and suggestions on how we can improve. All right, go ahead, David. Thank you.
Thank you. Afternoon, all. My name is David Hudak. I'm the Protocol and Equipment Coordinator for Pinellas County EMS. And as Dr. Jamison said, this was a presentation that I did this morning that we're gonna repeat and look for some feedback on some of the information that I presented this morning. So with that, generally speaking, the mission of the system is we want to make a positive difference in every individual with whom we make contact with. And that could potentially be my family or your family, visitors to the county, anybody that we intimately come into contact with. And with that, what do we do as a system to support that general mission? So we've done several things as a system. We've deployed stat packs as a standardized set of response gear for the system, and that is aimed at patient safety. It was an area that was determined that was a potential for, or was a contributing issue to errors that were occurring. And so this is a patient safety related upgrade. We work hard to obtain as many medications as we can in a pre-filled format because it's been shown that they're safer to administer to a patient in terms of reduction of drug errors as opposed to drawing up from vials. We've deployed major trauma bags as a preparedness component. There's a wealth of education and training being done with the initial training coming into the system and then ongoing training to address education throughout the system. Right now, we support issuance or deployment of life vests into the system for the educators to address part of the drowning chain of survival as a part of prevention. There's new vehicles that are being deployed throughout the system. This is the new Rescue 65. So from a preparedness and operations standpoint, there's money invested in these for response vehicles, as well as the investment by Sunstar for the BLS ambulance fleet, which takes a load off of the interfacility transports so that they can focus on the ALS response in the field. So with that, why comes up as a big question with all of the following. So the first one is why aren't cyber keys charged on a regular basis? And this is to ensure that the optimal connection between the key and a lock to access, say, for example, midazolam for the seizure patient. In the event that you can't get in and the patient's seizing, it becomes a patient-related issue. Why aren't the key tips periodically cleaned? There are stainless steel brushes that have been deployed throughout the system to ensure that we have a good contact both between the lock and the key. Again, to ensure that there's no delay in accessing the controlled substance box. So for example, utilizing fentanyl etomidate for performing facilitated innovation. Why isn't a standard inventory standard? The whole intent of this project was to ensure that regardless who showed up on the scene of a call, the equipment was in the same spot every single time, so that it would not delay or potentially contribute to a patient error or error in patient care. Why do we keep asking ourselves why we continually encounter ECG cable failures when we're preloading ECG wet gel electrodes? Wet gel electrodes, the vast majority of it's made up of water. So if they're exposed to the air, they're drying out. And at that point in time, it changes not only the application on the skin, but it changes the impedance, which then prevents the wire from detecting a proper signal, which results ultimately in the lead failure. Why do we keep asking ourselves why we are continually encountering ECG cable failures when caustic cleaning agents on the cable snap heads are being utilized? Whether it's bleach or the germicidal cleaners, what they do is they leave the chlorides on there and that transmits a signal. So when the device either does an auto test and or you're utilizing it during patient care, it's picking up the crystals that are left over. And so subsequently, it causes a cable failure or signal failure, which is why we've been so emphatic about utilizing alcohol primarily and hydrogen peroxide if necessary. Why do we pack the QCPR meter with the cable so tight that the damage results, preventing it from being in an operational ready state? The QCPR meters are approximately $1,200 each. And when they're packed this way, they're packed so tight in there that the cable, you can see on the one end where the cable is forcibly bent, which ends up breaking the wires on the inside, as well as damaging the adhesive pad on the opposite side of the QCPR meter. Why is the protective cover to the therapy cable removed in the field, never replaced and never found? The protective cover, this protective cover is integral to the safe use of the device during critical components of therapy from the device, defibrillation, pacing, and cardioversion. Why do we use a cardiac monitor in the rain and are surprised when it fails to work properly? Why are orange combat application tourniquets used for training? Why is it okay to crush the ECG electrodes and then wonder why we encounter failure of the cardiac monitor to detect a signal? When they're packaged like this goes back again to the water and the setup of the gel and the specific electrode. And subsequently, this is what happens when they get packaged or bent in those packages when there's too many of them stuffed in the backside of the monitor. So what happens is you have electrodes that already have a memory to them, and the gel has already been squished out of the center. So if you consider like an ultrasound, how much gel that they utilize for an ultrasound signal, if you remove a tad bit out of the ECG electrode, it's going to cause you difficulty in the field. All of these, again, come back to the inability to provide safe and appropriate patient care. These are some additional ones where, again, they already have a memory to them and you're trying to apply them. So when the incident reports come in and it states, we took them off and reapplied the electrodes, what's occurring is you're taking a next pouch, which is in the same set of these ones that have been crushed, and reapplying them again. And you're encountering the exact same scenario. Why is this okay? No explanation as to how it happened, and then wrap it in duct tape and continue to use it on a patient. Why are loose electrodes dumped into the case either to dry out if someone's ultimately attempting to use them during patient care, or otherwise, if they're just dumped in there, that's a huge cost to the system that the money could be utilized for other important things in terms of patient care. Why are these masks going to be used on a patient? So not only are the electrodes tied in there, but now there's several face masks that are in there. So I'm not sure exactly who's going to put that on, whether it was intended to be put on a patient or intended to put on ourselves. Either way, it's inappropriate. Why is this okay? A $25,000 medical device, a potential conduit for a healthcare acquired infection, or even COVID-19. So we focus so much on ourselves from a PPE standpoint, but we've got equipment that potentially is transmitting other diseases. Why is this okay? Again, a $25,000 medical device, a potential conduit for a healthcare acquired infection or COVID-19. Why is this okay? Like, once again, it's actually disgusting and gross that we would even consider that this is being utilized between patients. Why is the vacuum hose on the suction unit not replaced every time the suction unit's used? The kit that comes deployed for putting a new new container back on the suction unit comes with all the appropriate hoses. From day one, all of the hoses were supposed to be discarded, regardless of whether anything got up into the tubes or not. The minute it gets turned on and stuck in someone's mouth or utilized during patient care, the whole entire setup is to be destroyed and replaced. Why is it okay to lose medical devices and just write up an IR that is lost without any effort to try and locate it? This is generally speaking, and this is not just isolated to the glucometer. That's just one example. It could be any of the medical devices that we carry in the system. Why is it that the gasket on all the O2 regulators is not replaced monthly? This is to ensure that you've got the best seal and you're not having to use a wrench to try and utilize to obtain a seal for the regulator to the bottle. It's a proactive step to ensure that when we apply oxygen to a patient, that they're getting it, that we're not encountering any difficulty during patient care. So can we fix it? I absolutely believe we can. It's possible, we're able, it's solvable and doable. I'm going to pause now for thoughts on exactly how that can occur and any other feedback at this point before we move on.
So please put your thoughts in the comments. They're being almost as quiet as LG was.
I can continue on while they think.
So one person says it's an accountability issue.
Agree.
Chief Barr says, well said, Uncle David.
I heard that one in LG this morning.
One of the things I did not say at this presentation that I did earlier this morning is that regardless of how you look at this from whether David Hudak's giving feedback, Dr. Jameson's giving feedback, it's coming from the training division, it's coming from Craig Hare, the EMS system as a whole. Regardless, if you take a funnel and you bring it all the way down to the point, every aspect of what we do in the system is about the patient. It's about taking care of the patient. So every piece of education that is created is about the patient. Every every piece of equipment that we buy or change to is about the patient. Every vehicle that we put into the system, it's about the patient. And that's where our focus needs to be. It's not David's, sending pictures back to agencies that I'm going nanny, hoo-hoo. I caught you again with a dirty monitor. That's not anywhere close to the point. The point is that this is going in to take care of somebody else. And it needs to be in its optimal condition, regardless of whether it's the monitor, an airway bag. If the zipper's broke, it needs to be changed out. If the suction unit's broke or torn up, it needs to be swapped out. We need to focus on the best we can on a successful care of the patient.
Yeah, I would just echo that. I talk a lot about how the pre-hospital environment is difficult because it's uncontrolled. There's factors outside of your control. There's limited resources. There's time pressure. There's external factors, and really why it's so different to practice medicine in the pre-hospital environment versus in the hospital. And given that, you really got to do whatever you can to optimize your conditions, your equipment, and your chances for successful care of that patient. Chris says, any direction on the type of monitor that the system will be going to when the MRXs are replaced. So maybe that's a worthwhile point. So Chris, yeah, we're getting towards the end of the life cycle of these monitors, but maybe David, and there is a evaluation committee and process being formed for selecting the next monitor. But that's still a bit away. So maybe David wants to comment on these monitors and where they are in their life cycle, and whether the failures that we're seeing are intrinsic to the monitor or more likely resulting from care and usage.
So the process, these are end of life officially February of 2022. The device is being removed according to Philips. So we have to make a transition by that point in time. The RFP will go out sometime, I believe, the first part of 2021. And then we'll wait and see what happens. There's only 3 players in the marketplace, Zoll, Stryker or Physio, which Stryker owns Physio, and Philips. Philips owns or purchased RDT. They also have a separate monitor that's new to the market as well. And I can't think of the name of it off the top of my head right now. But as Dr. Jameson had indicated, a lot of what we're seeing with the monitors is not monitor related. By all means, there are some. We've had Bluetooth card failures. We've had end-tidal CO2 card failures. So one of the earlier presentations I did to the system is that these anymore are no different than carrying around a desktop computer, if you will. So most of the insides of them are all computer boards. So there's 4, 5 boards inside the Philips and a capacitor. And that's pretty much it. The rest of it's all the connectors on the outside. And so how we handle them certainly plays into how well or how durable, quote unquote, they are. For instance, we had one the other day that came in for a reported cable failure there, which it was unable to be reproduced. But while I evaluated it, at some point in time, there were enough indicators that it had been dropped. Both of the cases were separated in half. There was a large chunk of it missing from the bottom. And so someone at some point in time knew that the device fell or whatever occurred to it. And at that point in time, it should have been pulled out for evaluation so that we're ensuring the highest level of reliability. The devices that come through here, we make an effort to ensure that all of the connectors are always as new and possible as they can be. Same thing with the cases, the handles, et cetera, et cetera. But the number of true reportable critical fail devices or device errors is very small compared to the rest of the stuff that goes on.
Chris also asked, maybe he didn't hear you say it, but he also asked, will life packs not be evaluated? And I think I heard you mention physio, but it's my understanding that every offering on the market will be evaluated. In case you weren't sure, Chris, when David says physio control is who makes life pack.
So I think it's important before we get new toys to make sure we know how to take care of the ones that we have. And we were talking about accountability. I think that's a really good thing. The other thing is the checks and balances. I think that sometimes if you're working with the same group of people all the time, I don't know if people are becoming complacent, or if it's just lack of communication, like making sure that somebody is cleaning off the monitor, or that this happened at the beginning of the shift or between calls before that the equipment's put away. But I think that this is definitely something that we could work on as a system together to make sure that we find a way to make sure we take a little bit better care of this before we get something new.
So somebody asked, is there a process of handoff, taking ownership of the equipment to determine the condition it's in when it is being handed off? And I think that probably varies by agency, how that exact handoff goes. But yeah, there's always a handoff of everything from the controlled substance key to responsibility for everything else.
But hopefully, with the implementation of PS tracks coming into play, that may aid in this. But again, I think it goes back to the first individual that a large part of it is the accountability aspect.
Between shifts and between patients.
Yep.
Yeah, I guess I would just say, like so many things in life, the golden rule applies. And, how would you like that monitor to look when it gets to be put on you or your family?
All right, so continuing on from a PPE standpoint for the system, and this is whether it's COVID related or in general. Right now, we are doing exceptionally well on all of these items at this point in time. The two areas that we are weak on currently are boot covers, and there's still some continuing investigation, if you will, to find out why boot covers and shoe covers are such an issue. I don't know if it's because the material is being allocated towards masks or what the issue is, but we're struggling to be able to get those, and we get them typically when we just about need them. So we've been able to maintain the inventory. It's just been difficult. Gloves, on the other hand, are becoming a major issue, and this is across the board, regardless of what aspect of industry you're in, whether you're in healthcare or the restaurant business or fleet or mechanics or whatever the scenario is. So right now there's a huge widespread shortage of gloves, and we further narrow that channel by the fact that we're currently utilizing NFPA compliant gloves. Most gloves are not NFPA compliant, so it makes it even more difficult for us to maintain inventory. So these are some of the recent headlines related to gloves, and we knew a lot of this based on communications that we have open communications with several distributors. And so we have been aggressively, since the beginning of COVID, sourcing inventory for the warehouse of both of the versions of glove, the Apex Pro and the LifeStar that we currently have in the system. Unfortunately, we got to the point where we can only buy so much because we were still waiting on the stuff to come in. And even though we had POs pending, right now they are basically saying, well, the price you had on your previous PO, here's your choice. you can pay more, or we're going to cancel your POs. So this information is from Ansel, who's one of the obviously the largest manufacturers of gloves, both nitrile and latex. Gloves are manufactured in pretty much 2 locations in the world, Malaysia and China. And Malaysia was shut down for the first part of COVID. So it backed up the pipeline even further. So the demand right now, they're estimating at 585 billion. They can only sustain 370 billion. So there's a 215 billion glove deficit, and which is obviously significant when you talk about international, because the glove issue right now is not just focused, it is an issue where they're getting draw from all over the world. We've experienced a 100% increase in the cost of a box of gloves. We were in the $12 range, and we're just shy of the $24 range a box of gloves right now. And that's the highest in my entire career that I've been here that we've paid for gloves. What we don't want to do is we don't want to remotely begin to think that either of these are an option. Either you're using washing mitts and or you're washing and cleaning disposable gloves. So we believe that we've sourced enough, but we're also on allocation at this point for gloves per the month. And so one of the things that we've learned about as the global supply chain has corrected itself, if you will, is that even though we could have had gloves and bought them for 6 months, the issue is that if you're not constantly purchasing, they're basing their allocation numbers on continual sales. And so it may have thrown your sales off related to the distributors. So we currently have an allocation of gloves from the distributors that we've had in the past. Unfortunately, that is not enough to sustain operations. So what we are hoping is that between the existing inventory that we have and what we are getting on allocation, that we'll be able to weather the storm, which is not the scenario for many, 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 many other folks at this point in time. And with that, there are some glove conservation strategies that need to be considered. So if you currently check your vehicles out with EMS gloves, it's probably time to find an alternative, because it's going to potentially put us in a jam when we can't get them to take care of patients. And again, this goes back to the patient. Increase the level of access control to existing inventory, preventing unauthorized access to inventory, monitoring supply requisitions from the agencies, and practicing first in, first out. So even if it's expired, which the boxes of gloves typically have a 3-year shelf life, the sterile gloves, I believe, are the same. They have a defined expiration date on them, that even if they're expired, they're not off the table for us to utilize. And that's according to the CDC, if you end up getting into glove conservation strategies where you don't have enough. So please do not discard them. Update related to the full face respirators. We're switching to the Moldex Series 9000 full face respirator. We will be ramping up distribution this week and next. The process for fit testing will be, initially we'll send a supply out to start doing 50% of the agency personnel as they test and determine what the prominent sizing is going to be and where they think or what they're going to need. We'll be able to supply additional at that point. They are individual issue, whereas right now they're shared masks. The individual assignment comes with the individual mask bag. Their filters are designed, this is the filter is the P100 filter, and it's got a filter cover that snaps on over top of it. We're switching to a different style goggle, and this is based on feedback specifically from the system, that the existing ones were fogging up, and it was a result of it overlapping or being underneath of an N95. So the 2 choices were, it was over top and you ended up with fogging, it was underneath and you got a good seal, but then your N95 was not sealed properly. So this one was brought to us from Dr. Jameson. They were utilizing them at Tampa General, and they were evaluated at a couple different agencies and as well as some EMS coordinators. They fit over most glasses. They've not experienced any of the fogging issues that were previously done. We have them on order, and as soon as we get them, we will deploy them. One of the other issues we were experiencing with the other ones is the across the bridge of the nose, they were splitting in half. And that's all I've got.
Thanks, David. Just a couple of clarifications. First, the goggles are not official to Tampa General. That's what some of the folks that work there came up with on their own. So they're not officially endorsed or anything like that. But we did evaluate them here in the system, and they seem to be working well. There was a question about the boot covers. Somebody's asking, they thought boot covers got removed.
They have been removed. Well, I shouldn't say that. Let me rephrase that. They've been placed as optional, so agencies still can utilize them. Regardless, we still need them in the system for future use.
Right. So the question was, they believe that they were removed from the most recent PPE recommendations, and they're not getting them in their agency put together isolation kits. So I think that's consistent with protocol and recommendation. Great. Any other questions for David on equipment issues? I want to take just a second and say thank you to David for his literally unending work over the last 8 months, keeping all of us safe. I know of no EMS system anywhere that has done as good a job at keeping their people protected and with appropriate and sufficient quantities of PPE. When I talk to folks from around the country, universally people are struggling with this, and I'm convinced that David and the folks at Sunstar Logistics and a bunch of other people who've worked very hard have done just an amazing job at keeping us all safe, frankly, which is no small feat in the midst of a global pandemic. So thank you, David. I really do appreciate it, and I know the field folks appreciate it as well, even if they don't always show their gratitude. So any other issues for David? I don't want to go too long. I think I might have missed a question back here earlier on antibodies. There was a few questions coming in. Okay, has there been any further research on how long the antibodies last? Riley asked. So there's stuff coming out that the antibodies may last 90 days or more or less. I think that still remains to be seen. What I would encourage you is that we don't know the full answer to that. So any data you want to contribute by getting tested would be great. The overall global medical community continues to learn every day about COVID, and any piece of data is helpful. The second thing I would say about that is that just because there's not a detectable antibody level does not necessarily mean that you have no immunity via other mechanisms. I think it's a useful data point. It may be useful for you in terms of your peace of mind or knowing or whatever, but it's probably mostly useful from understanding what our cumulative experience as first responders has been in terms of getting exposed and preventing exposures as we go through this. So I would encourage everybody to take advantage of it. It is voluntary. There's no penalty for not doing it or anything like that. But the county is spending a significant amount of money to ensure that this is available to everybody in the system. And so I would encourage you to avail yourself of that.
There was another question about if you've been tested at a local clinic, would you recommend doing the IgG test with the county as well?
Yeah, I think I answered that one from Holly. Yes, I would recommend. I don't know which kind of test they do at the clinic, and as everybody knows, testing has been a bit of our Achilles heel as we've gone through this. You know, there's so many different tests and different sensitivities and specificities and all that other stuff. I'm very highly confident in the test that we're using from the hospital. In fact, it's one that we used as the reference test when we were trying to find a finger stick test that would work for us. And so even if you have been previously tested, I don't know how long it's been since you've been tested. I don't know which kind of test it is. I would suggest that you take advantage of this opportunity for the free test for not only for yourself, but for the larger first responder community. All right. So any other questions before we wrap it up for the day? We'll continue trying to do these every 2 weeks or so. If you have a suggestion for somebody that you'd like us to bring on as a guest, I will do everything I can to try and get that person to join us. We've had a few guests in the past that I thought went pretty well, so we'll continue to try to do that. I thought our mental health professionals that joined us a couple weeks ago was especially helpful. So
I have something to add.
Go ahead.
On the 28th of September, we are doing a open Zoom meeting to whoever wants to attend for mental health with Baycare. So there's going to be a flyer coming out on that soon. I don't believe we have another live stream before that. So just keep an eye out for that. And that's, everybody will join the Zoom meeting, and there'll be a little presentation by Baycare, and it'll be an open forum for everybody to talk. So keep an eye out for that. And that is at 1500 on the 28th.
Awesome. All right, seeing no further comments. David, any last thoughts?
No, sir. It's been a long day.
It's not
Every
even
day.
it's not even close to over, David. But in any case, thank you everybody for tuning in, and we will see you next time. Please stay safe out there.
See you in 2 weeks or on the 28th.